Good evening, everyone. I hope you're all well and welcome to our webinar on cataract surgery. My name's Jane and I'm your presenter this evening. Our expert presenter, Mr. Wallace Poon, Consultant Ophthalmic Surgeon at Benenden Hospital, is our expert presenter this evening. His presentation will be followed by a Q&A session. If you'd like to ask a question, please do so via the Q&A icon, which is at the bottom of your screen. This can be done with or without giving your name. Just to remind you that this webinar is being recorded, although the other attendees won't know that you're taking part unless you give your name when asking a question. If you prefer not to be recorded, now is your opportunity to leave the webinar. I'll now hand over to Mr. Poon and you'll hear from me again shortly. Thank you.
Thank you, Jane, for the kind introduction. Good evening, everyone. Welcome to the webinar on cataract. I am Wallace Poon, one of the 12 consultant eye surgeons practicing at Benenden. When I was asked to prepare a talk on cataract, I think it is very fitting that I approach the subject from your perspective. As my dad just had his cataract surgeries done in the US a few months ago, the discussion we had was very useful for his decision-making process. So a few things about myself. I received my medical training at King's College London. Then I did my eye training at London and South East. I then did a vitreoretinal fellowship at St. Thomas's Hospital, London. What that means is a more advanced surgical training to deal with the retina. I was then appointed as a consultant vitreoretinal surgeon at East Kent Hospitals. I specialize in trauma of the eye, retinal detachment, complicated cataract surgeries, cataract surgery complications. Now, on average, I do around 1,000 plus cataract per year and total more than 12,000 cataracts to date. I'm also an honorary lecturer at the University of Kent, supervising post-PhD students on clinical application of medical imaging. I'm also the UK examiner for the European Board of Ophthalmologists. Now, this is the list of questions my dad addressed, which I borrowed for this talk. And hopefully you'll find the answers useful at the end of the webinar. So number one, most importantly, what is a cataract? The different types of cataract. What causes cataract? Do I have cataract? If I do have cataract, do I need surgery? What do I expect after the surgery? What happens during the surgery? What can go wrong with the operation? And where and which surgeon to do my operation? On the left-hand diagram you see here is the frontal view of the eye. The right, where the arrow is pointing, is the cross-section of the eye. That means cutting the eye into half. This is the front, this is the back. The cornea is a transparent structure there. You can see through, that shows the color of the iris. And in the center, that's the aperture called the pupil. And behind the pupil is the natural lens, which is inside a capsule. I like to tell my patients that the eye works like a camera. The image of the light came through the eyes, focused by the lens and the cornea, onto the retina. The retina functions like the film of the camera, as you can see here. So what is cataract then? Cataract means the natural lens lost its transparency. In the left diagram, you can see the image was very sharply focused on retina, but in comparison to the right, the rays are going everywhere, and you can see the image is compromised. Many reasons why people suffer from cataract. Congenital means you're born with the cataract. It could be traumatic. What that means is, for example, a patient with a penetrating eye injury punctures the capsule and the cataract can be formed within days. It could be related to systemic diseases. For example, diabetic patients tend to have cataract sooner rather than later. Could be drug related. If you're on long-term oral or topical steroid eye drops, that can cause a cataract. but by far the commonest cause is age-related. There are different types of cataract: nucleus sclerosis, cortical lens opacity, posterior subcapsular cataract, posterior polar cataract, and we're going to look into them in more details. On the right side, you can see a well-dilated pupil with the lens behind with a yellowish color. This is typical nucleus sclerosis cataract. What that means is the lens material gets denser, and that's why it becomes yellow. It can progress quite slowly. Commonly, this is age-related. And what you may find out is the vision become blurry and the color start to fade, especially in the blue spectrum of the color. Cortical lens opacity looks different. On the right-hand side here, you can see the spoke-line appearances of the lens. The opacity tends to appear in the anterior part or the front part of the lens. Typically, patients suffer from cortical lens opacity, notice a lot of glare. This is posterior subcapsular lens opacity. Now, if I can convince you, you're looking at the back of the lens. This is the shape of the lens. This is the front, that's the back. This type of cataract tends to progress quite quickly, and is more common on younger patients, especially if they're diabetic. Posterior polar cataract is different. You can see here, the opacity is right in the middle and at the back of the lens. So on the cross section, it will be right down there. This tends to be congenital and get worse with time. The cataract itself can be fused with the capsule which is holding it, and that increases the risk of complications during surgery. So do I have cataract then? If you notice the colors start to fade, things become blurry, oncoming traffic light cause a lot of glare, or you keep changing your glasses, getting more and more short-sighted, or you got double vision with one eye closed, quite likely you do have cataract. What is next? Go to see your optometrist. They are highly qualified professionals. They're the first line of defense of your eye health. They'll be finding sight-threatening disease and refer to the hospital eye service. For example, cataract, retinal detachment, wet macular degeneration, and some of the opticians also co-manage chronic eye diseases with their doctors. For example, the community glaucoma network, where you do have glaucoma, you see the optician, and then the eye consultants will see a result remotely, and then you'll manage not necessarily going to the hospital at all. Some of the opticians also manage what we call the minor eye emergency service in conjunction with the hospital eye service. So you don't need to go to the eye casualty to be seen, but seen by your local optometrist. So what will the optometrist do to make the diagnosis? First of all, they will check your visual acuity. Hopefully your eyesight will not be as poor. They will check your refraction. That means finding out how long or short-sighted you are and whether you've got astigmatism. And they will perform a slit lamp examination, which is the bright light on the machine that allows us to see a magnified image at your eye. They will check the pressure in the eye, see whether you've got glaucoma, and then they will put some drops into your eye, then examine the back of the eye. Some opticians are more equipped, and they might have got other fantastic machines that will help the diagnosis or taking record. One, they can do fundal photos, that means taking a picture of the back of the eye, or their special scans now allow us to see the detailed structure of the macula. The macula is the center of the retina responsible for all the detailed vision. And I think the optician quite likely will start discussing what to expect after surgery. They will probably talk about refractive outcome and the choice of lens implants you can have, mainly the monofocal or special lenses. And then you will refer you will be referred to the ophthalmologist for further assessment. Now, what do I expect after surgery? As I mentioned earlier, we will talk about the lens implant and the refractive outcome. Mind you, this is quite a difficult concept to understand. My own experience, my dad, is not most encouraging. We spent half an hour talking about the lens implant and things. And at the end of the conversation, I asked him, so what do you think? And he said, whatever your choice is. And then I said, so do you understand what I'm saying about? And he said, not really. So I hope you will do better, and I will try my best again to explain to you. Monofocal lenses. That's the commonest lenses we put inside the eye after cataract surgery. Mono means one point of focus only. That is, either is good for distance vision when you're driving or watching the television, or just for near vision when you're reading or sewing, but not for both. That means you will need glasses one way or the other. Astigmatism is not corrected. You might think, what is astigmatism? That means the surface of the cornea ideally should be like a football. However, a lot of people were shaped more like rugby ball, and this will not be corrected with the monofocal lenses. The monofocal lenses implantation are performed by most ophthalmologists, either under the NHS or as a self-pay patient. Special lenses are different. They have got the toric element to correct astigmatism, and the multifocal lenses is a bit like internalizing the varifocal glasses. So rather than wearing it, they internalize it. And what that means is it will be able to provide good distance and near functional vision without the use of corrective lenses. However, patients can have glare or reduced contrast sensitivity with this type of lenses. So it is not suitable for everyone, and especially patients with certain conditions. For example, irregular astigmatism, glaucoma, or disease at the back of the eye. It is performed or should be performed by ophthalmologists which specialize in refractive surgery. And unfortunately, this is not available under the NHS. Just a quick graphic summary. In the left-hand side picture, you can see the monofocal lenses. So you need glasses for distance and or near. NHS patients, self-pay patients, or Benenden member patients can all have the monofocal lenses. But the multifocal or toric lenses, you can see here, you've got this nice, very fine groove. And what it does is allows you, most likely, will not need glasses for distance nor near, and is only available as a self-pay package. So you'll be referred to the ophthalmologist for further assessment. You can choose to go to the NHS, which only monofocal lenses available, or you can consider, if you want special lenses, as a self-pay patient. Some interesting facts with the COVID pandemic. According to the March reports from the Royal College of Ophthalmologists this year, before the COVID pandemics, in the UK, we perform around 450,000 cataracts per year. But this dropped by 44%, nearly 200,000 cases during the COVID period. As a result, there's long waiting time for even an appointment. Of course, that depends on which part of the country. For example, my colleagues in London telling me their CCG, they've got over 2,000 patients, waited more than 18 months to have an appointment. Certain part of Kent, for example, in East Kent, they've got community providers for cataract. The waiting time tend to be less. But however, the waiting time is a bit longer than what it used to be. There is extra government funding, but I think it will still take time for the process to go through, as because the number of patients will compound as the time goes by. So do I need cataract operation? there are clinical reasons which I will encourage you to have cataract surgery. For example, you got angle closure glaucoma. What that means is the cataract becomes so big, it blocks the drainage pathway in the eye, and as a result, there's a risk that pressure in the eye can go sky high and you can go blind very quickly. Or this could be part of a vitreoretinal procedure. What that means is I have to do operation at the back of the eye. I might just as well remove your cataract. Otherwise, you will need surgery sooner rather than later. Or the cataract is affecting the quality of fundal image. If you're diabetic, you probably will have fundal images by the diabetic screening surface. If you have cataract, it blocks the light entering and they cannot take a decent picture to grade your diabetic disease. If you don't have the above, do you think you need cataract surgery? Only if it's affecting your daily life. If you're not seeing well to cook, to shop, or you start driving with hesitancy because of the glare affecting you, or you might actually not reaching the government required legal standards, or you start changing your glasses very frequently because you're getting more short-sighted, or if it's affecting your hobbies. For example, you're playing golf in sports, you can't find the ball again, or if you enjoy painting. Especially if you're a famous painter like Claude Monet. I think you all know he's a French impressionist. He was diagnosed with cataract in 1912. His symptoms getting worse and worse over the next 11 years. He was very hesitant to have surgery because 1912, the surgery are not as advanced as we are today. He was describing his garden become very yellow and very murky, and the red becomes very dull, and the blue becomes darker and indistinct. It is very obvious in his painting in the different years on the Japanese footbridge. As you can see in this picture, this is drawn in 1899. Very clear image. The color is vivid. The same footbridge was drawn in 1922. You can see the image is quite indistinct and he used very dark color. If I can convince you, this is actually the bridge. So what happens during cataract surgery? Now, in the old days, couching is the method of choice. Now you can see here, a needle or lancet is inserted into the eye and the cataract kind of wiggle a bit and fell to the back of the eye. The other picture shows you this patient's well prepared for surgery as he's strapped to the chair securely. It is interesting to know that the payments are made to the surgeon since 1750. However, if the patient died or lost vision, the surgeon's finger will be chopped off. Now, I'm very pleased to tell you that all my fingers and thumbs are intact. So modern day cataract surgery is very different. You can see my younger self there operating. This is the operating microscope, which provides precision and also magnified three-dimensional image of the eye. The phaco emulsification machine allows a controlled microenvironment for the surgery to be performed. And also you can see here the micro instruments are very robust, very reliable. And the most important thing is the development and the continuous advance in the intraocular lens implant. It was first introduced by Sir Harold Wrigley at St. Thomas's Hospital, first inserted in November 1949. Things has moved on a lot now, and now the lens is much smaller and is foldable, allowing micro incision. So when I do the operation, the incision is around 2.1 millimeter. As a result, you don't need any more stitches, it's self-sealed. And the advance of special lenses especially now enables nearly complete visual rehabilitation. That means allowing you to see distance and near. So the gold standard in UK is phacoemulsification and intraocular lens implant. This is one of the most commonly performed surgical interventions worldwide, with a very high success rate. In the UK, according to the data from the government, 90.6% of the patient will reach driving vision. There are patients which has got other coexisting disease, which of course that will hamper their recovery. So what happened on the day of surgery at Benenden? Now, I would advise you to wear comfortable and dark color clothing. Have a light meal and definitely no alcohol. You'll be surprised, I do have patients which is so intoxicated after cancel the surgery. Making sure you arrive on time, making sure you follow the latest COVID protocol. When you arrived, we will check your blood pressure, the glucose, we'll put more drops to dilate the pupil, and we'll give you oral sedation if you're very nervous. The surgeon will then come to see you, checking you're the right patient, checking the consent, making sure the lens selection is correct, and then mark the site for surgery. Then you'll be led by a nurse into the eye theater. There will be the surgeon there, a scrub nurse, and also the runner. So it's not going to be overcrowded. You'll be sit on the operating chair. We'll put a cap to pull back all your hair from the face so we won't interfere with the operation. We'll have a gauze to cover your ear on the side of surgery. We advise you to take your hearing aid out on that side, and then we'll cover that to make sure there will be no water will go into your ear during the operation. We will again check your identity, and then we'll put a small pulse oximeter on your finger, just to make sure your heart is beating and your oxygen content inside the body is adequate. The operating chair will then move backwards. We're making sure you're comfortable. We put a pillow underneath your knees because I want you to be comfortable so you won't start wiggling. We'll put more local anesthetics and iodine solutions in the eye. Now you'll notice because of the iodine solution, everything turns a bit brown. That's to be expected. Then I will clean the eye and then put a drape across. Now, what we mean by a drape is a surgical sterilized piece of plastic which covers the surgical area. It will cause a bit of claustrophobia, but can be lifted away from your face. We then insert a speculum. You can see the metallic things on here to keep your eye open. You might notice a tiny bit of pressure, but it should not be painful. And then you'll be asked to stare at the operating microscope light, which will be 3 bright dots. Make sure you have both eyes open and you can blink normally. You can listen to the music, but no singing or dancing. So what will I do then? The different surgical steps. We'll make a small incision on the cornea, as I said, around 2 millimeters, to go inside the eye. We'll do what I call the capsulorhexis, is to peel off the top of the capsule, which is surrounding the cataract itself. And then the phacoemulsification, what that means is ultrasonic needle that will insert into the eye, sending ultrasonic wave to break the cataract. And then during that period, you will hear some high-pitched noises. Once the cataract is removed, we'll do what we call irrigation and aspiration to making sure the whole bag will be cleaned. Again, you'll hear some noise. And the lens implant will be put inside the eye. Antibiotics will be given, and then we'll seal the wound. And then you'll be covered with a transparent shield, which you can see through but blurry. The whole process takes around 10 to 15 minutes. Now I want to show you a bit about the surgery at the stage what we call the capsulorhexis. As you can see here, we are peeling off a very small area of the capsule. And I also want to draw your attention. The space here is very, very small to maneuver. The total length of the eyeball is around 24 to 25 millimeters. And the area we're operating has got only 2 to 3 millimeter depth. Hence, any sudden movement can be devastating. That's the phaco emulsification. You can see the phaco needle inserted into the eye, ultrasonic wave, emulsified the cataract pieces and clean it all out. And then we'll put the lens implant in. You can see here, the lens is inside the cannula, is folded, go through a small wound, and it opens up. Operation done. So what can go wrong then? There could be complications during the operation. The commonest is what we call posterior capsule rupture. As I explained to you, the lens is inside a capsule. 1 in 100 cases, when we do the operation, the capsule can be broken. But what that means is we might need to do extra procedure to clear the vitreous, which is the jelly structure moving forward, and then put the lens implant in. Now, it might not actually affect the outcome whatsoever, but that means slightly longer operation. If the capsule rupture is a lot bigger, part of the cataract can drop to the back of the eye, as you can see here. This is a picture taken at the back of the eye. This happens around 1 in 150 cases, so it's not common, but that means you will need further surgery to remove the cataract at a later stage. The thing we worried most with any eye surgery is endothermitis. This happened post-operatively, and it happened around 1 in 1,200 cases. As you can see in the picture here, the eye is quite red, and you can see there's a white line. Now that is white blood cells, or we say pus, inside the eye. Because of the bacteria entering the eye, the whole eye becomes infected. We can still treat it, however, the outcome might not be as favorable. And very rarely, 1 in 10,000 patients can permanently lose the sight and lose the eye. And this is why, unless necessary, we do not want to perform an operation in your eye. And you can see here, if I can convince you, the cornea lost its transparency a bit. This is due to swelling, or what we call corneal edema, following cataract operation. It is not uncommon. It happens around 1 in 100 cases, and the majority of the swelling will clear with time or with some eye drops. However, 1 in 1,000 patients might need further surgery to clear that. Post-operatively, you can also have what we call systomic edema. This is the OCT scan I mentioned earlier. This is looking at the anatomy of the back of the eye. This is the macula. This is what a normal macula should look like. Nice and smooth with a dip in the center. And you can tell here, the back of the eye is swollen. It happened at 1.2% to 3.4% of patients having cataract operation. Some of them are so mild, it won't even affect your vision. Majority of patients, again, will recover with some eye drops. Following the surgery, even months to years later, patients can have capsular thickening. What that means is the capsule that was holding the lens implant had grown thicker. And as a result here, if I can convince you, you can see this opacity, which is causing problem again and blocking the light entering the eye. It happened to 5 to 10% of cases that underwent cataract surgery, but it can easily dealt with some laser, what we call YAG laser capsulotomy. If I can convince you, the same patient here had the opening created by the laser treatment. And because the light can go through, your vision should return to normal. So the next question is, where and which surgeon to do your surgery. In America, my father I'm now only practicing the cataract surgery exclusively at Benenden. My reason is the eye department is located in a brand new £53 million facility. There's plenty of parking space. I know it's quite trivial, but it is sometimes very important, especially in a very tranquil environment, and you don't feel to be rushed. And Benenden has got the latest investigative and surgical equipment. What is also important, I'm working with a team of 12 experienced eye consultants. Every day of the week, there will be clinic and surgical sessions. What is important is we cross-cover each other. That means if I'm going on holiday, there will be someone looking at your eyes if you've got a problem. And my colleagues covers most eye subspecialties, from oculoplastic, which is to do with the skin of the eye, or to do with the medical retina side, or vitreoretinal surgery. And we've got 4 refractive surgeons, especially dealing with the special lenses implantation. What is also very important and behind the scene is the hard work by our lead clinician, the matron Jane, the senior management team, the CEO, the medical director. They instill a very strong clinical governance culture. What I mean by that is the complications, complaints, surgical outcomes are scrutinized. Not to mention, we've got a dedicated team of ophthalmic nurses and administrative staff. And they created a very well-designed cataract patient pathway. Why is that important? This is what we call a one-stop cataract clinic. Either it's for monofocal lenses or special lenses. When you come, the nurses will take your history, do your blood pressure, check your visual acuity, check your pressure in the eye, and they will done all the investigations. Biometry means to measure the shape of your eye so we know what lens implant we have to choose. If you're in the special lenses clinic, they do a special scan of the front part of the eye. They will do the OCT scan, they will sort out your COVID protocol, and then you come to see me. That means by the time you see the consultant, all I need to do is concentrate during the eye examination. I can look at the results, then I can talk to you and discuss what lens implant is suitable for you. Other places I work is very different. What I mean by that, you're not having a linear process. This is all zigzag. You'll come to see me in one establishment and I say, oh, you need a scan. And you might end up in the optician doing a scan because some of the establishment don't even have a scan. And then you come back to see me and then say, yes, you need surgery. And then you're going to have the biometry measures. And then you come back to me. And then we talk about the lenses. And then we haven't got the lenses in place. It needs to be specially ordered. Benenden is very different in the sense that you only come once, we get all these things done, we get you consented, and I can tell you, if you're self-pay patients, most likely you will have your surgery done within 3 weeks. Also, what is important is after the surgery, you will have 24 hours post-surgery hotline. So anything you're concerned, you're not happy with, ring the number, there will be someone to answer your call. So where is an obvious choice for me? Because that's where I'm going to practice my cataract surgery. And which consultant? That will depend. It could be your friends or family recommendation. It could be subspecialty related. For example, you want to have special lenses, and I recommended you to have the operation done by a refractive surgeons, or you have got previous retinal detachment or other things which might be more appropriate for certain consultants to consult you and operate on you. Any of our 12 eye consultants at Benenden, they're experienced, they're trustworthy, and we practice to a very high standard with your interest in heart. Now, these are the list of the questions in the beginning. I hope I managed to answer that. just a message you take home. If you got the symptoms of cataract, go to see optometrist. If the following applies, which is, if you want to see and operated speedily by one of our 12 experienced eye consultants, if you want special lenses, you want a streamlined service, you want 24 hours hotline following the surgery, all you need to do is ask your optometrist for a copy of the referral letter. And then you call the Benenden private teams, if you're a Benenden member or a self-pay patient. This is a number for our private patient consultation team. So ring this number if you're interested to see us. And now it's the Q&A session. So please ask me any questions if you wanted to.
Thank you so much for that, Mr. Poon. It was really interesting. I've worked in eyes for 12 years and I've learned something, so that's always worth it. So I do have some questions for you. So I'm just going to start at the top and work my way down. I have a question. We have a lady that's got sight only in one eye, and on the other eye she has already had cataract surgery, but she wonders whether this could be done again but with special lenses.
I will recommend not to have special lenses because you will like the two eye functions in junction to each other. So I think, unfortunately, if you have one monofocal lenses put in, it will be better to have the similar property of lens to be implanted.
Okay, so quite a common question that we get. What is the criteria for cataract surgery? People talk about ripeness and size. Could this please be explained?
Yes, as I mentioned earlier, the most important thing is the cataract affecting your daily life? For example, I mentioned about, is it compromising your vision? Are you driving? If you're driving, are you having the symptoms that is causing you losing your confidence because of the glare? Or are you actually reaching the government standard? Or is it affecting your hobbies? Those are the things you need to consider. Cataract can be done earlier or later. Depends what your living style is.
Absolutely. So I have a question regarding glaucoma. So I have glaucoma for which I take 2 eye drops. How does this affect my cataract operation?
Well, first of all, it depends on how advanced your glaucoma is. If you've been told by your glaucoma specialist you've got advanced glaucoma, it will be better for the surgery done by himself or his colleague. The reason for that is when you perform cataract surgery, there will be fluctuation in the pressure inside the eye during the operation. And there's a very small chance that can damage the optic nerve further. So if you're on 2 eye drops, that means you might have slightly advanced glaucoma. We are still able to do the cataract surgery for you, providing we have got all your medical notes to find out how advanced your cataract operation is, how advanced your glaucoma is, so we can advise you accordingly.
So another very common question, can the procedure be done under general anaesthetic? Because I am totally terrified of the prospect of having it done whilst awake.
Yes, it can be done under general anesthetics, but unfortunately at Benenden, we only perform the surgery under local anesthetics. Generally speaking, in the UK nowadays, over 95% of cataract surgery are under local anesthetics. Of course, if you're very terrified or you're so nervous you can't keep still, general anesthetics might be the only option forward.
Okay. I have a question. I've heard that people have been fitted with monofocal lenses, one for long sight and one for short sight. Is that a possibility, and would you recommend it?
Yes, it is possible. And this is why I said the refractive outcome is quite difficult to explain and to understand. What basically is happening is you will have one eye for long distance and one eye for short distance. That means for reading. So at any moment of the time, you're only utilizing one eye to perform the function. Now, this is not necessarily suitable for everyone because the two eyes has got what we call refractive difference. So because one is long, one is short, and some patients might find it very difficult to cope. What we will advise is you might be better to see an optician before you contemplating to have what we call this is monovision. Might be to try the lenses or try contact lenses and see whether you can cope with the different distances before we actually contemplating doing surgery. Because once the lens implant is put in, we cannot, or it can be reverted. It's better not to, because that means it's more operation and risk to complications. Or you might end up still wearing contact lenses afterwards, which will defeat the objects.
So I have a retinal vein occlusion in my right eye. Am I still able to have cataract surgery in both eyes?
The answer is yes. And I think if you got central retinal vein occlusion in one eye, I think we'll suggest not to have the special lenses, but have the monofocal lenses. But surely you can still have cataract surgery.
So can toric and monofocal be combined if paid for?
Yes. What we call by the special lenses is it can do two things. It can correct your astigmatism, which is the toric lenses, or it can have the multifocal capability. Those two characters can be combined, or you can just have the toric lenses with the monofocal lenses combined together.
So I have an occasional chronic cough. Is it necessary to remain very still during surgery? If so, what do I do if I need to cough?
Now, yes, you will need to keep still during surgery. The reason, as I explained earlier, is we have got a very confined space to operate on you. You can suddenly see the movement can cause devastating effects. However, because you're awake, and I will tell you if you have got tendency to cough, we will say, before you cough, raise your hand. So if I got instruments inside the eye, I can withdraw them quickly, and then you can cough. Of course, this is not the ideal situation, but I've been operating on patients which do have coughing episodes, and we safely have the operation performed.
So I have an attendee that has glaucoma and has had laser for the glaucoma in the past. I wonder whether this would affect cataract surgery.
That would depend on what type of laser surgery the patient had, because you can have laser to create a hole on the iris. Sometimes that will make the surgery a bit more challenging, because after the laser was performed, it will induce inflammation in the eye, and the pupil can get stuck and not dilating well. It is still able to have the operation done, but it might need extra tools to help us to dilate the pupil. But the answer is yes, it can be done.
So I have an attendee that asks, if you need further correction for your vision, can you wear contact lenses after cataract surgery?
The answer is yes, you can wear contact lenses, and sometimes even glasses will be sufficient.
An attendee doesn't currently have cataracts, but would a special lens replacement prevent cataracts developing in the future?
As I mentioned earlier, any surgery carries a risk that things can go wrong. You can have what we call clear lens extraction. That means you have got the normal lenses, but because of the lifestyle, you don't want to wear glasses. And that procedure can be performed. And of course, once the natural lens has been removed and replaced with the lens implant, you will not develop cataract in the future.
And finally, this is the last question, I believe. An attendee, tell a lie, another one's turned up. We have an attendee that has cataract forming and has done for several years, but they're not actually affecting the quality of life yet. So they seem quite comfortable that they should wait a little bit longer. Would you agree with that?
Yes, I would. That's why I told my dad. I think if you're not bothered with the symptoms and you're coping with your daily life, leave it for now.
Okay. And the final question, I believe, which I may be able to answer a little bit better, is what is the cost for special lenses? That varies. So when you come for a special lens assessment, the consultant will be with you for a long time talking about the variety of lenses which would be suitable for you. At which point, once the lens is chosen, then we will let you know how much they cost. But for a private patient, you're looking at approximately about £3,500 per eye, depending on lenses. Okay, well, I think, I've had another question pop up. One moment. Post-op activities, what should be avoided, Mr. Poon?
Now, traditionally, the cataract surgery involved quite a large incision, and you might have got stitches in the eye. We tend to ask the patient refrain from any